Ahora sí. Nice. So, good night, everyone. My grand rounds. My name is Pamela. I'm one of the fellows that are working here in La Familia Hospital. So I'm gonna start with this case. So the first time he came into the clinic was in May 12th of 2021. It's a masculine patient of 70 years old from Chiapas, Mexico. His chief complaint was itching and diminished visual acuity of 3 years, both eyes. Also, he got a past history of cirrhosis diagnosed 5 years ago, treated with Lasix and propranolol. No family history, no history of past surgeries. And the ocular examination, best visual acuity was light perception, right eye 18, the IOP. It was a clear cornea, deep anterior chamber with pseudoexfoliation, and it was described as a hard rock cataract. Gonioscopy was no description, and left eye was hand motion, IOP of 14, and slit lamp was a clear cornea, deep anterior chamber, pseudoexfoliation, hard rock cataract, and gonioscopy was no description. So by this time, with the IOP normal and the rest of the exam, our plan was to do an M6 both eyes. So 3 years later, because he disappeared and he didn't come to the visit for the surgery, he appeared, and next time saw him, it was January 22 of 2024 this year. It was a masculine, 70 years old, from the same place. The chief complaint was diminished visual acuity of 5 years, both eyes. He said that he has lost his appointment for surgery, the same past medical history, just that he added hypertension to his past history. No treatment, no family history, no history of past surgeries. But this time, the ocular examination, the right eye was light perception colors, the IOP was 29, and slit lamp, he got RAPD, blepharitis, nasal and temporal pterygium, shallow anterior chamber, pseudoexfoliation, dense cataract, and phacodonesis. The gonioscopy was a narrow angle, and on the left eye was hand motion, IOP 17, slit lamp, blepharitis, nasal pterygium, shallow anterior chamber, pseudoexfoliation, and a dense cataract. Normal pupil reactions, and the gonioscopy was narrow. So by this time, our plan was a little bit different. PI, both eyes, M6, both eyes, lowering IOP, and treatment for blepharitis. We decided to start with the left eye because of the RAPD. He got a better prognosis for his left eye, so we decided to start with that eye. So we do surgery on him, and this was his post-op. The right eye, like I said, we didn't do surgery on that eye, or we haven't. Left eye visual acuity after the surgery was 2400. Optic nerve, the radial was completely like 1. So it was completely cupped. You can see the pupil was brown, even though we have to do sphincterotomy during surgery because this patient didn't dilate well. So I'm going to talk about a little bit about cataract surgery and pseudoexfoliation. Pseudoexfoliation, it's a multifactorial illness. It's genetically determined, it's age-related, and it's environmentally influenced. So this disorder is characterized by elastic fibers that are there's an excessive production and an accumulation of elastotic material in these tissues, intra and extraocular tissues. It's the most identifiable cause of open-angle glaucoma. Talking about a little bit about the prevalence is thinking that it's 60 and 7 millions of people worldwide that has this pseudoexfoliation. Also, they are the 20 to 25% of the patients with glaucoma, and 2/3 of the 2 of 3 patients are presented unilateral, but actually that's the most common way of presentation, but it's a systemic condition, so we usually can diagnose before the illness that we saw clinical characteristics in the eye. So if we do a biopsy of the contralateral eye, we could find that already has this condition, but usually its presentation is unilateral. And obviously the prevalence increases with age. The geographic variation in USA and Western Europe, the prevalence is very similar. I'm sorry, I'm just going to connect my computer because I'm running out of battery. I'm sorry. So in lower latitudes, it's common that they have early presentation of the illness. Also, the distance from Ecuador and sun exposure that is very common in our patients, it's make the prevalence go higher, and also the elevation. Lower ambient temperature, it's also related to prevalence and coffee consumption. The prognosis of this patient, it's not really good because they have 5 to 10 times more risk of developing glaucoma. Also, 25% of this patient develop elevated IOP. They have greater IOP fluctuations. They are more resistant to medical therapy. They have more serious clinical course and worse prognosis, and they're more likely to have glaucomatous damage. The etiology, genetic and not genetic, there are some variants in the gene lysyl oxidase type 1, and also no genetic causes. It can be trauma or prior intraocular surgery or autoimmunity or infectious agents. Oh, and we have that in with a interrogation sign because it's not yet proved. There are investigations about that. And how is this pseudoexfoliation causing glaucoma? The pressure elevation, it's caused by resistance in the trabecular meshwork. This is due to blockage of the aqueous drainage by pseudoexfoliation material. The main effect is in accumulation of the juxtacanalicular tissue. It happens beneath the inner wall of Schlemm's canal. And it has been studied that pseudoexfoliation is locally produced by endothelial cells lying in Schlemm canal. Some ocular signs that we can see is the classic appearance of pseudoexfoliation. It's a deposit of white material on the anterior lens surface. There, usually we can see 3 zones: central disc, intermediate, that is a clear zone because of the rubbing of the iris, and also granular peripheral zone. So there's some other picture. The A is the early stage, the B is the central zone, and C is the granular zone, and we can see like we can see the layers. Also, the most characteristically, it's exfoliation material on the pupillary border or the loose of or absent pupillary rough on the eye on your left. You can see the rough because this eye, it's not involved. It's the same patient, and the eye with the B letter, it's the patient that it's involved with pseudoexfoliation, and it has absent pupillary rough. Also, we can see in the gonioscopy increased trabecular pigmentation and sphincter transillumination. And what is common is to see pigment dispersion, especially after dilating these patients. And exfoliation material may be detected earliest on the ciliary processes and sonals, and we cannot see that. And because of all of that I mentioned, it's also phacodonesis is common and can be also subluxation of or dislocation of the lens in previous to cataract surgery. So these patients tend to have a lot of complications during the cataract extractions. So here are some tips for preoperative patients. The first thing is that we need to identify ocular signs and the presence of pseudoexfoliation material with advanced cataracts, especially. It's really hard sometimes because of the contrast with the color, but it's really important to recognize it. To evaluate the sonular integrity. Also, sonular laxity, it's not related or it's not due to the amount or extension of the pseudoexfoliation material. It's more related to the age of the patient. So if you're gonna have a pseudoexfoliation material, you want a younger one to be, and you don't want an older one. With phacodonesis, lens subluxation in this patient, it's up to 8.4 to 10% of the patient with pseudoexfoliation. Iridodonesis, it's less common in this patient because you have an increased rigidity of the ischemic atrophic iris. Also, you have poor dilation, so we recommend using pre-op NSAIDs to help maintain maximum dilation, or using other things that I'm gonna mention intraoperative. Specular microscopy, it's important because this patient usually have diminished count of endothelial cells. It can be by two causes. The direct cause, it's because of accumulation of the pseudoexfoliation material between endothelial cells and descemet membrane. And the indirect cause, it's because high OP of this patient, iris ischemia, and increased flare of blood aqueous barrier breakdown. The IOP, it's also important to assess, and because of the prevalence of glaucoma in these patients. Intraoperative, you need to achieve sufficient pupil dilation. We can use OBD combination. Usually we can use dispersive to coat the corneal endothelium and cohesive to centrally to deepen the anterior chamber, flatten the anterior chamber. But in this patient, we do not want to overinflate because we have more sonal damage. For posterior synechia, we can use a blunt spatula or stretch the iris carefully with manipulation because of the ischemic iris that I already mentioned. We can also use iris hooks and pupillary rings. You can assess sonular weakness during capsular vexes. The first sign is that you are not gonna be able to puncture the capsule when you are gonna start your capsulotomy. So they recommend a 25 gauge needle bent at the tip, like the capsulotomy we almost with every case use, or also we can do bimanual technique with capsule hook.
But Pame, are you going to talk about some of the signs of the when you're doing a capsulotomy, what you have to look for?
Like folds in the capsulotomy.
Mm-hmm.
Folds are one of the signs. Also, that it's not like behaving well. Usually, when you're doing your capsulorhexis, the vectors are not working the way you want to go. I don't know if you.
Yeah, it kind of tells you where the you got weak zonules, so you really have to look for those folds on the anterior capsule when you're doing the capsulotomy.
Okay.
But go ahead, keep on. I just wanted to mention
Okay.
that. Mhm.
Thank you.
Yeah.
Also, intraoperative, we can use CTRs or capsular retractors are very common in this patient. Capsular retractor, we usually help to support the sonular lens complex in the anterior posterior direction and to facilitate hydrodissection and cataract fragmentation, while the CTRs we usually use to distend the capsular bag, supporting areas of sonular distance and redistributing the sonular tension so we can have like a center lens after putting in. If the sonular weakness is really extensive, we can use modified CTRs that we have to fixate it to sclera. For this patient, it's very common to use chop technique, vertical and horizontally, because we allow minimal sonular stress maneuvers in the center of the anterior chamber. If we're doing another techniques, we can put a little bit of stress in sonules. We can have vitreous prolapse before and during due to sonular weakness. I mean, you can start your case and already have vitreous in the anterior chamber and without touching anything. And we have those cases. Also, you need to do a limited anterior vitrectomy and tamponade with OVD. IOL depends on every case. Usually after CTR, one-piece IOL requires less manipulation because of the risk of decentration and capsular contraction. Multifocals and torics with these patients are not a good option. We try to avoid sulcus due to probability of decentration after, and no anterior chamber because we have high risk of glaucoma in this patient and also corneal decompensation. So we don't like anterior chamber lens.
Just a couple of comments there. I tend to do a three-piece IOL with the haptics in the sulcus and with the optic capture. So that centers the IOL very well. And
Okay.
that's one. And try to avoid the plate IOLs in the bag. You know, the ones that do not have haptics. They're just a big plate. Because of exactly what you're going to mention, because sometimes there is capsular phimosis and it's not complete, and that can compress the lens, and I have seen some lenses almost popping out of the capsule because of the phimosis. So try to avoid those plate lenses as well.
Okay.
Mm-hmm.
Wait.
Quick comment. Sorry, I'm on a bullet train from Kyoto to Tokyo. It's kind of noisy. When you're rotating the nucleus, just like you said, you want to avoid stress on the zonules. So if you rotate your nucleus, you want to do a 2-point rotation. So you're rotating about the center of the visual axis, so that minimizes stress on the zonules. So if you want to rotate, you take one instrument, push one way, second instrument goes the other way. So you're rotating the lens with 2 points of fixation. And then when you're stripping the cortex, normally we strip the cortex from in that it stresses the zonule. So you do what Alan Crandall described as a hurricane IA. So you grab the cortex and you strip it trying to minimize stress on the zonules is about not stressing, the zonule. And then in terms of IOLs, perfect echoes on these patients, and 10, 12, 15 years later, I'm sure Andy's seen this, Jorge, echo, they're 20/20, and 10 or 15 years later, the lens starts to sink. And so I think I've switched to putting sulcus lenses and as I said, because it really depends on the age of the patient. If you think they're going to live 5 or 10 years, you have to think about late IOL decentration. Very, very common in these patients.
Okay. Yeah, usually when we do M6 on this patient, we do by manual extraction of the back nucleus because we don't like to stress the zonules. Thank you, Dr. Tanaka. So postoperative, we have higher degree of postoperative anterior chamber inflammation. It's due to chronic alteration of blood aqueous barrier. They usually accompanies the iris ischemic changes that it's in this patient. Also, we expect severe post-op fibrinous uveitis, and we need to check for synechia, capsule contraction, and CME. Pressure spikes is very common in this patient. There's also risk of endothelial cell loss, and capsular phimosis is very common in this patient. So we can do radial anterior relaxing JAK laser capsulotomy, like you can see on the picture right here in the bottom. And this is references, and these are some pictures of other patients from the clinic because we have a lot of pseudoexfoliation and we saw this patient every day.
Great presentation.
Yeah, it's great.
Yeah, one more. Go ahead.
No, go ahead, George.
Comment about, yeah, so a lot of times we'll use miotics intraoperatively, like myostat, to bring the pupil down or control the pressure. Miotics disrupt the blood aqueous barrier. So if you use a miotic intraoperatively in these patients, be prepared for a very significant fibrinoid reaction. Just extent, their blood aqueous barrier is already compromised, and the miotic is going to make that even worse. So if you use it sparingly and just be prepared for a lot of postoperative inflammation.
Okay.
I never heard that, George. So with giving them Myocol on post-op day 1, you'll see more fibrinoid reaction.
Yeah, you'll see a lot of fibrin. Sometimes you'll see almost like a second lens form. There's so much fibrin in the eye, depending on how weak their blood aqueous barrier.
And related to the miotic.
Correct. Right.
Interesting. I was going to ask Pamela two questions. One is there with the deposition of that fibrinoid material, that elastic material rather, where else in the body is that seen, and does it have any other physiologic impact in kidneys or any other part of the body? That's one question. And then my second just kind of comment is I generally, I see these lenses late when they dislocate, they get referred to me to fix them. And so I do if there's a 3-piece lens in, what I'll do, unless they've fully dislocated, I'll just move them back into position and put a mechanical suture to the iris, and I find that works just really, really well. So, but I can't do that with a plate, and it's harder to do with a one-piece lens because the haptic is so broad. But those, so sometimes on a pseudoexfoliative eye, if I think it's going to be an issue, I'll preferentially put in a 3-piece lens, and sometimes I'll even put a mechanical suture at the time of the original cataract surgery. But usually it's something we'll do later. But I'm just wondering about that a question about seeing the material elsewhere in the body. Is there any other?
Yeah, there is systemic association with vasculopathies, include ischemic attacks, strokes, and myocardial infarction, cerebrovascular insufficiency, and Alzheimer patients.
Alzheimer's too. And to my knowledge, it still has not been reported except in one paper now within Guatemala, the incidence of exfoliation. So it's
really high in the Mayan Indians. They have so much. We saw a lot of it in Guatemala, and you know, Andy, in the Bay Area, we see if you take a sample of their muscle in the thigh, the liver, the kidney, everywhere in the body, and you look at it under electron microscopy, you will see this stuff. And we know the Russians have a very high incidence of cardiovascular disease. That's probably related. I don't know what it does in the Mayan population. But with respect to your question about the IOL, if somebody's got a single piece in the bag and it's dislocated, what you can do, you could put in a Gore-Tex suture and lasso the haptic through a scleral groove. You know, there's a lot of videos on that. That works pretty well, you know, without having to take out the lens and do an exchange and anterior vitrectomy. If it's mildly dislocated, you can just, there's videos on this where you dock needles, a Gore-Tex needle, and bring it out of scleral groove and just tie it down. There's also using I think type of loop through a scleral groove, and then you can actually just blunt the ends with a cautery, just like with a Yamani technique.
And then Jeff just put the link up there from Alan Crandall's paper on pseudoexfoliation in Guatemala. That's from 2021. And I think that Daschle contacted this author, Patrice Hicks, to maybe do a follow-up study. So it'd be interesting to see if I'll reach out to him and see if he's still interested in that project. But that'd be a good project for someone to take over if it hasn't been done.
To add to your question, Andy, we have seen deafness or loss of hearing associated to pseudoexfoliation, and that's very frequent also in the elderly Mayan population. So that's yeah.
Interesting. Let me ask Andy. So when you get these cases referred for dislocation, I tend to see the pressures go really high as the lens descends. Do you think that's because as the lens is dislocating, you get all this liberation of pseudoexfoliation from the zonular fibers?
Yeah, I don't know.
You see that too, Andy? I know.
Yeah, I see that a lot. Yeah.
You don't check the pressure.
Do you think the mechanism
lens.
Do you think the mechanism is the liberation of that material? I've wondered also if in the general lack of zonular structure and integrity, once the lens dislocates, if that translates to the ciliary body and the angle structures further losing their structural integrity, just because the whole iris at that point is
so you get reduced out, right?
Yeah, there's also a lot of
maybe get some reduced
back
out
of the iris.
Yeah, could be all those.
Yeah,
but it tends to get better once you fix the lens and do something about the pressure.
Yeah.
Do you usually combine those with any types of MIGS procedures, or do anything about the pressure, just kind of manage it medical?
Are you asking Jeff?
if I see a lot of damage, I'll try to do something. I'll maybe do a Zen or a pressure stays low. MIGS could also work if it's not too advanced.
I think once you fixate the IOL away from the iris, seems to resolve mostly.
But one last question. Are the pseudoexfoliatives more receptive to SLT as a therapeutic for pressure?
Respond well to SLT. It's a great option.
Mm-hmm.
If you have a reasonable chance of getting the pressure to a safe level. You don't do it with an IOP of 40, you're not going to get where you need to be.
Malik, go ahead.
I just think it's fun to raise my hand on these calls. So. First of all, I just want to point out how dedicated George is to education, doing this on a bullet train, and maintaining.
Sitting in the bathroom because it's the only quiet place. Hopefully nobody needs to use the bathroom, so I'm going to have to leave suddenly.
That might have been too much. That might have been too much sharing there, George.
Okay.
So just a couple of things. I think I was waiting for the MIGS conversation. I think anytime you go in and there's high pressure, we should try and do something about it, but we don't always have the tools available. One thing that's done more in Germany for some reason compared to anywhere else in the world is just washing the trabecular meshwork. So if you don't have any extra tools, and keeping in mind that you don't want to damage the cornea for all the reasons that you presented, you could do extra irrigation aspiration and wash out some of the pseudoexfoliative material. The downside for SLT and just washing out, so those two things, you get a dramatic decrease in pressure, but it doesn't last very long. So SLT is super responsive, but short lasting. Same thing with doing a washout, super responsive to it. That's why you get these dramatic decreases after cataract surgery in a lot of cases, but then the pressure tends to go back up. It's also important to note that after you remove the cataract, you're still developing pseudoexfoliation material in the angle. That's something that's common where, we say we took the cataract out, the patient should be okay. But that pseudoexfoliation material isn't just coming from the capsule, it's coming from all tissues that have a basement membrane inside of the eye. So I think one thing that you can do in the short term until you get the patient back on the medicine is a little bit of that washout. And we can talk about technique at some point. But great presentation. You hit all of the high points for pseudoexfoliation. I thought you did a great job.
Thank you.
Yeah, great presentation from me. I also, just to add, I also do goniotomy on these patients. I think they do very well. They respond very well to goniotomies. So if there's any other comment, but I just want to congratulate you doing pseudoexfoliation is very frequent.
Yeah, great presentation. For this patient, just make sure you get all of his relatives checked too, siblings, kids, because it does run in families.
Okay.
And then maybe pass that paper idea on to one of the fellows, you or one of our upcoming fellows. That would be a great great study. If you're interested in that, we should maybe you and Jorge can. Or you and Jorge or Jorge Tanaka can work on that. Or okay. Jorge Emmerich. All Jorge's.
All right.
Thanks, everybody. It's great.
All right, thanks. Yep.
Pamela, excelente.
Thank you. Good night, everyone.
Good night, everyone. Thank you for joining. See you on 2 weeks.